Thank you, Subhashish. Thank you, SWB, for this wonderful opportunity and a great webinar that we are having. I was asked to speak about COVID-19. How safe are we doing oculoplasty and oncology? I would be talking about end-to-end safety and universal precautions. This has already been covered by various speakers: patient protection, patient screening, and triage on arrival, screening by history, physical distancing while waiting. I would like to stress on maintaining a daily list of all healthcare workers, patients, and their attendants who come into the hospital, and making it mandatory for them to download Arogya Setu if they have a smartphone. We always maintain physical distancing in the OPD, do exam room precautions, wear PPE where required. And most important aspect that I would like to stress on in evaluation is avoid syringing and nasal endoscopy unless it is mandatory. So alternative to syringing would be a fluorescein dye disappearance test, which is considered as sensitive as syringing in diagnosing nasolacrimal duct obstructions. But of course, we have to rule out lower lid atonicity and also lacrimal pump mechanism failure, where FDDT would also be positive. So that is something that we would like to avoid. Rest of it is all the same. And then let's go to surgery straight. What are the specific guidelines for oculoplasty and oncology? We don't have to have a full PPE for most of the oculoplastic procedures unless the patient is positive. For example, if a COVID patient has a mucormycosis and we have to do orbital exentration to as a life salvage measure, then the surgeon and the entire team has to wear full PPE. Otherwise, it is not really required. We have a series of 3 articles that were consensus or preferred practice pattern that were published in IGO. One was about AIOS Oculoplasty Association of India consensus on oculoplasty and lacrimal surgery. Here we categorized orbital and eyelid and facial plastic surgeries into level A, level B, and level C, simply meaning emergency, urgent, and elective. Emergency would mean that these patients would need immediate care or at least in 1 to 2 days. Urgent would mean less than a week or maximum 2 weeks. And elective, where they can be postponed to 5 to 6 weeks. Now, as you see here, the list is very, very succinct. You know that canthotomy and cantholysis in site-threatening orbital hemorrhage, drainage of a orbital or periorbital abscess, exentration for life-threatening infections such as mucor, as I said, or malignancy are actually emergencies that can save life and that have to be done on an emergent basis. Or if the patient is very symptomatic in an eye with endophthalmitis or panophthalmitis, where you have to do a destructive procedure, where a patient has an orbital fracture and has an oculocardiac reflex for which you have to do an orbital fracture on an emergency basis. Rest of the procedures actually are not emergency, but they can be urgent, like plaque brachytherapy for intraocular malignancy is urgent, it is not emergent. So you can wait a little bit. Whereas other surgeries such as socket reconstruction can wait for months. Orbital decompression for specifically cosmetic rehabilitation is an elective procedure. So elective procedures can wait. Emergency has to be done irrespective of whatever risk you need to take. But of course, we have to protect ourselves. Urgent are some cases are sometimes can be deferred for a few days, but they still have to be performed. In eyelid and facial plastic surgery, the main emergencies are periocular malignancies, severe unilateral ptosis in an infant where the ptosis is near total. It's not actually an emergency, but it can be considered as an urgent surgery. Eyelid lacerations and tarsorrhaphy for impending corneal compromise. Symptomatic entropion, etc. can be deferred. Now, in lacrimal surgery, there was a specific guideline which was published in the last issue, where any child or adult who has acute infection or acute inflammation can be considered emergency. If a child has bilateral dacrocystocele with airway compromise, because dacrocystoceles like this can have an intranasal extension, thus causing airway compromise, those are considered emergency. What we are currently avoiding are routine nasolacrimal duct obstructions for DCR, which obviously are considered high risk and are best avoided at this point in time. In ocular oncology, actually nothing really has changed. All malignant eyelid tumors are being managed exactly as we were managing earlier. except that sentinel lymph node biopsy can be deferred by a few weeks. Otherwise, everything else is as per pre-COVID era. Follow-up can be little deferred, but follow-up is important. Benign eyelid tumors, of course, are non-emergency. Now, in malignant conjunctival tumors, again, there is absolutely no change in protocol. But if a patient can be managed with topical therapies such as topical mitomycin, 5-fluorouracil, or interferon, that may be preferred if that is possible, considering the efficacy and safety of the patient put together. That may be preferable as opposed to surgery. If that is not possible, you would go ahead with surgery as per the protocol, because these are malignancies and can threaten life anyway. Benign conjunctival lesions are deferred. In retinoblastoma, nothing has changed. In fact, this was the only condition where no delay was affordable, in the sense that all through the lockdown, in fact, complete lockdown when it was there in the country, we were doing examination under anesthesia, chemotherapy, treatment for retinoblastoma, because these children go into enucleation or orbital extension if that was not done. As we are observing, some patients who did not come during the lockdown and could not consult specialists in their own geographic location have come back with the tumor filling the entire eye or with extraocular or optic nerve extension, now threatening their life. So any delay in retinoblastoma management is simply cannot be justified. So retinoblastoma is going on exactly as was earlier. Same with melanoma. We are not deferring anything in melanoma. Everything is being performed as it was. In orbital malignant tumors, again, there is absolutely no change in protocol. Benign tumors which have no visual consequence can be deferred, or if a patient doesn't have diplopia or anything which is functionally disturbing, that can be deferred. Do tears trouble? Well, there are many articles which show that the viral load in tears is extremely low. Of course, DNA has been isolated, but viral load is almost to the extent that it is non-infective. So if there is a tear to eye transmission, patients tear transmitting to the healthcare worker's eye, that has never been documented. In fact, the first case that was actually thought to be a tear transmission in the glaucoma specialist in Wuhan is not a tear transmission, it was respiratory transmission. That has been now established. So there is no single case of tear to eye transmission that has happened so far. Is the sinus safe? Not really. So ENT specialty has the highest risk, we know that. So if you are doing a procedure that involves a sinus, such as orbital exentration, where we have to do radical exentration, etc., then a full PPE is required. If a surgery involves getting into the sinus, such as orbital decompression, where we decompress into the ethmoid, that is avoided in favor of a deep lateral decompression, where sinus is not touched at all. Floor is not touched, because again you get into the sinus. Orbital fractures, again you get into the sinus, so you have to be very careful deal with orbital fractures. Can cautery laser ablation create a problem? Not really. This is actually a misconception. Every article currently published in the COVID era is quoting evidence of viral based lesions such as a papilloma, which when ablated using a radiofrequency electrode or a cautery or laser definitely creates plume, and that is viral particles. Or a HIV related lesion which has been ablated, that has viral particles. But if, say for example, a COVID patient, we know that the transmission is respiratory. It is not aerosol generated by tissue vaporization. It is aerosol generated by the respiratory process. So there is no evidence at all that plume that is generated by tissue vaporization in a non-virally created lesion, such as if I am ablating skin for blepharoplasty, that is not going to cause infection, because that doesn't have any viral load. So one of the famous quotes is that everyone wants to know when this will all end. Well, that is not the right question. The right question is, how do we continue? We cannot stop doing what we are doing just because this infection is there. We cannot trivialize it either. So we have to rationalize, classify our surgical procedures in oculoplasty and oncology as elective, urgent, and emergency, and triad appropriate patient for surgery. We prefer local anesthesia over general anesthesia. In fact, We are even doing skin grafts and mucous membrane grafts under local anesthesia. It has to be quick in and out. There is no point lingering on in the OT. Expert surgeon using a standard procedure as quickly as possible, minimize surgical steps so that you get similar results by minimal surgical steps. Personal protection for patients, healthcare workers, and surgeons in that order. Cautery, we prefer bipolar over monopolar in low settings. We don't avoid cautery, but we use a safer form of cautery. Avoid routine surgeries where PNS is transgressed. Avoiding routine DCR, which still doesn't have evidence, but well, of course, getting into the nose has its risks, so we avoid DCRs, and extra care for patients on chemotherapy. So we have to prepare or perish, and readiness is the key. And these are the points that I already made as to what are the components of the new normal in oculoplasty and oncology. So I'd like to stress on end-to-end safety, right from patient entry to surgery and post-operative care, taking universal precaution in every patient that we deal with. Of course, COVID-19 has several unknowns, and things are getting unwrapped as we go. It is best to protect but not to overreact. We should not shut down what we are doing in our own interest and in the interest of patients, because we know that more than 60% of population has to be ultimately infected, including us, infected, to get kind of herd immunity that we expect and the disease to burn itself out. So COVID is here to stay, so we have to embrace the new normal. April, May, and June issues of IGO have several preferred practice publications, and if you have more information, if you need more information, you can go through this. Uh, Out of about, Sunny just gave me information that out of 450 articles published on COVID, IGO has about 50 in ophthalmology. So that's quite a creditable thing. Thank you so much.